TopMedTalk.
Well, hello and welcome to TopMedTalk. I'm Desiree, Chappell, your host and editor-in-chief of TopMedTalk, and I'm joined by our co-editor of TopMedTalk, Monty Mythen. Hello, Monty.
Good afternoon, Desiree. Day 2 of the SCA 2022. It's good to be here. It is
day 2 of the Society of Cardiovascular Anesthesiologists, their annual meeting in Palm Springs. It is good to be here. A little warm.
Yeah, let's not complain. First world problem. We're not going to get sympathy.
Road. No, we're not.
From people. Not. The air conditioning is working in this splendid building. So it's a first world problem.
Yes, it is. But actually, Monty, it's a lot of fun to be back out on the road. This is kind of our first go around besides the ASA this last fall.
But with a proper, we've touched on the podcast we've done so far. There's over 1,000 people here.
Yeah.
And they're excited to see each other.
Yeah.
It's good to be back.
We're all excited. So I'm excited to see everybody and have some really, really cool conversations. Last time we were SCA was in 2019 in Chicago, wasn't it?
Yeah, just pre the thing that we don't mention anymore.
Yeah.
that viral thingy, which we hope has gone.
Yeah. As Andy Shaw put it earlier, mid-pandemic, but hopefully post-pandemic.
Well, I mean, it's happening in many parts of the world at the moment. So, but on the basis of our experience, we hope it's mainly passed, and it will pass for them too. So let's all keep praying for that.
That's right. Well, we had some really good conversations back in 2019. We've been able to continue that, kind of a continuation of some of those conversations this weekend so far. Monty, anything that you've been surprised by, anything new and late breaking that you've been hearing here at the meeting?
So, I thought Andy Shaw, I referred on the fact that the president, Andy Shaw, who we know very, very well, long-term friend of mine, gave a great speech last night, which also reflected on the challenges of the last few years. But he also shared with us this morning in a podcast his ambition going forward. Mm-hmm. And I thought it was very bold, the global ambition, the leadership ambition, and the perioperative medicine ambition, very typical of Andy in the SCA to be looking over the horizon and the horizon after next.
Yeah.
And also very much the approach of team. Yes. It's all about team.
We've heard that a lot. We hear that a lot on TopMedTalk in the world of perioperative medicine. So, we love to have more conversations around that. Today, this afternoon is no different. So, Monty, we're going to introduce our guest here. We have Dr. Emily Methangkool. She is a cardiac anesthesiologist from the University of California in Los Angeles. She's vice chair of quality and patient safety at the UCLA Department of Anesthesiology and Perioperative Medicine. Emily, thank you so much for joining us.
Thank you so much. Good afternoon. Thanks so much for having me.
Yes, I hope I pronounced your name right.
It was perfect.
The TopMedTalk listeners know that I'm from Kentucky, and there's something about my accent that makes it very difficult to pronounce names.
Oh, no, it was great.
Good. Well, Emily, I know you've been very busy during the meeting. Mm-hmm. Tell us just a little bit more about yourself and, your involvement with the SCA.
Yeah. So the SCA is one of my favorite organizations. I've actually been involved with it since I graduated as a fellow in 2013. Been part of the problem-based learning discussions, have given some lectures as part of the workshops. A couple of years ago, was asked to join the scientific program committee. So had a hand in creating the program for the 2018 meeting and the 2020 meeting, which got canceled. And then the virtual 21 meeting, and then this meeting. So it's been a really, really great experience. And then other than that, have made so many good connections, and the SCA got to connect with a bunch of women here, helped found the Women in Cardiothoracic Anesthesia Special Interest Group in 2018, which was just a hodgepodge group of women that came together who were kind of focused on growing leadership in women in the SCA. And we've grown significantly since 2018. We're a big group now in 2022.
I went past the your special interest group meeting last night. It was busting at the seams. It sounded like a party.
It really was. There were over 100 people there. We were very, very happy.
Yeah, that's awesome.
And then in 2020, got elected as an early career director of the board. So I've been on the board of directors for the past 2 years, and it's been really exciting to be a part of the board and getting to know Andy Shaw and Chris Troyanos and all these amazing SCA leaders. It's been really great.
Yeah.
Awesome. So Emily, if you look back to your first meeting, how long ago did you say that was? It's always rude to discuss.
2013 was probably my first meeting.
So we're going back 9 years ago.
9 years ago.
Have you seen quite a transition in? I know you've been part of forming it in the program, the contents, in 2013, were we all about discussing physiology and the heart and methods and mediators? And have we transitioned to a different world? I know that's still important. But,
yes. I would say 100% yes. I would say in 2013, a lot of focus on kind of the science, the basic physiology, anatomy, echo. We still have that kind of focus here at the SCA, but I think there are more practical things that we talk about. I mean, the lecture this morning about professionalism in the operating room, that would have not been a lecture in a 2013 SCA.
Wouldn't have been allowed.
No,
maybe not. Yeah.
There's a problem with that.
But I think there's this increasing recognition of kind of the communication problems that we have, not just in the cardiac surgical operating room, but, in anesthesia and in operating rooms in general. This year was the first year we had a professional development workshop, actually focused on kind of early and mid-career faculty, helping them work out, issues with negotiation, leadership skills, creating their elevator pitches. That's not something we would have seen in a previous SCA. So I think the SC has moved really, really far in creating really great content for its members.
Yeah. Well, I love it. And what Andy and I were talking about too, the international presence that I have noticed at this meeting. I mean, there are people from all over the world.
Yeah. It's really, really great. I mean, cardiac anesthesia is a small community, but, there's a lot of connections with EACTA, or what's EACTA stand? European Association of Cardiothoracic Anesthesia. Yep. There's, I think, a liaison from EACTA on the board. So very close connections internationally.
Yeah. Small but broad.
Yes, for sure.
Well, Emily, tell us a little bit about some of the things that are really important to you as a cardiac anesthesiologist, as an, anesthesia and perioperative medicine in general. What are some of your passions?
Yeah. So I finished training in cardiac anesthesia and became faculty at UCLA. Once I became faculty, I realized that there were a lot of problems that we were dealing with, adverse events that would keep coming up again and again. And unfortunately, a lot of those adverse events were happening in the non-operating room locations. For example, endoscopy, cardiac catheterization laboratory, interventional radiology. So what was the reason behind that? Got a lot more interested in that, got involved in our Quality Improvement Committee, eventually took over as chair of that committee, and then was appointed as vice chair of quality and safety in 2020 for the department. And in my role, I review all of the adverse events, basically work on ways to kind of learn from those events, opportunities for improvement, opportunities for better teamwork and collaboration with the teams that are working in these locations.
So I can't remember the exact figure, and maybe you would know the percentage of adverse events that are actually in the non-operating, anesthesia, the room, non-operating room anesthesia, Nora. Do you have any figures, at least for your department there? Or comparatively,
I would say, the bulk of our case, the bulk of events, adverse events that happen are obviously in the operating room locations because they do a lot more anesthetics, right? But in proportion to the number of the anesthetics, the adverse events that are in these non-operating room locations is much higher, unfortunately.
Yeah.
And they're often related to things like communication problems, respiratory events, lack of recognition of when things are going wrong, teamwork issues, those kinds of things are kind of the precipitators for these events.
So if I was looking in from the outside and I didn't understand exactly the world you're talking about, and you were saying that you've gone away from the operating room, which I've kind of seen on the TV, and there's lots of people concentrating on everything, and there's lots of machines and lots of things measuring things, and it looks very, very safe indeed. I think you're saying you've gone to another place, maybe we're going to be extreme now in the basement, for example, possibly.
I'm not sure that's extreme. I think that may be a reality for a lot of people, unfortunately.
And now they're doing a procedure that's potentially painful, and there's been a request to provide anesthesia, but it doesn't have all of that kit in there. Is that one of the challenges?
It definitely is one of the challenges. So the challenges are multi-pronged, I guess. It's both location, the team involved, the patients involved. So in terms of location, these are areas that could be very far away from the main operating room, in the basement or multiple
3
floors
buildings away.
or even in a different building. And what that means is that you don't have the resources that you typically have in the operating room, right? You don't have additional anesthesia personnel. You don't have your anesthesia technicians who can bring you equipment. And then the people who are working in those locations aren't necessarily as familiar with working in an operating room environment. They're not used to that anesthesiologist, surgeon, circulator, nurse dynamic where, in the operating room, the surgeon kind of knows what the anesthesiologist is doing. The anesthesiologist knows what the surgeon is doing. And the circulator nurse knows how to manage both the anesthesiologist and the surgeon. And for example, where to go get the things that the surgeon or the anesthesiologist needs. And that's not necessarily the case in these off-site or out of operating room locations, right? For example, if you are sedating a patient in MRI, you may not even have a nurse available to help you. You may just have a radiology technician who is running the MRI machine, and they may not know what an endotracheal tube is. They may not know how to run and get the thing that you need. So
or I'm like, hey, can you squeeze the bag for me? And they're like, what?
Yeah, exactly.
We never know who's listening. So
Not
we don't
that
want to
that's a bad
scare
thing.
people too much.
No, oh no,
But,
yeah, right.
but we are dealing with the reality of it.
It is,
yeah. So how can we make that safer?
So I think a lot of it comes to communication,
Okay.
I will say. So how do we improve communication in these areas? A lot of it is also education about what we're doing. So on the anesthesiologist side, when we are in these cases with the interventional radiologists and with these gastroenterologists who are actually doing a lot of very advanced things, we as anesthesiologists may not necessarily appreciate how high risk these procedures are. And, there could be potential for lots of bleeding. They could be working very close to an artery. We should be prepared. And that kind of thing really needs to have a preoperative conversation and also preoperative optimization for maybe patients who aren't good candidates for that kind of procedure. And then we also have to have some kind of way to communicate with our nurses and technicians on what are the needs of the anesthesia team. This is what it means when we're inducing a patient. This is why you should probably stand next to us when we're inducing the patient. This is how to get emergency equipment, or this is what we mean when we need an LMA or an endotracheal tube or a glide scope. So that kind of thing. Basically, we need protocols to communicate with these multidisciplinary teams better. And also, I think there's a good opportunity for team training, simulations, not necessarily in a simulation center, but just running through cases in the location that you're going to be working at with the teams that you're going to be working with can be really, really helpful.
Yeah, absolutely. I mean, we did MH drills and all these mock codes and stuff like that in the OR.
Yes.
And everybody, I mean, that is something we talk about is the communication and assigning roles and all those things. You never do that in the endoscopy suite.
No, you don't. But I mean, we're providing anesthesia. It can be just as dangerous in the endoscopy suite as in the OR, and you probably should.
Yeah. So what are some of the strides that you are taking as, the vice chair of quality of patient safety? What are some of the things that you're doing, especially that, I might be able to take back to my facility?
So one thing that we're actually doing is we are trying to create a hyper focus around non-operating room anesthesia. And we're actually creating an entire position. So we are recruiting a director of non-operating room anesthesia who will specifically be tasked with, creating these protocols and working very closely with our quality liaisons in interventional radiology and gastroenterology to create those team trainings. So basically we're going to recruit first, and then we will work together to create, team training events for these locations.
Yeah. Well, that's great. I mean, that's great work. I'm just thinking in my mind, I'm like, that is something, honestly, we need to have a conversation about, I mean, this is we've been doing this type of anesthesia for a long time, it seems like, but the scale of it now has just changed so much. I mean, we're adding points of service at facilities all over just to cover this stuff, right?
Right. And I think, we're expanding our services all over the place. I think the last study that was done on non-operating room anesthesia was in was published in 2017, but the data was from 2014. And at that time, they said about 35% of all anesthetics were done in the non-operating room locations. But our procedures and technology has advanced so much that the percentage of anesthetics that we do outside of the OR is probably way more than 35% in 2022.
Oh, absolutely.
Now, bearing in mind, let's imagine I'm not from our team and I'm coming from the outside. I would imagine that when you go to those locations, you'd take more experienced providers. You'd have more monitoring because it's a more remote environment, and you might have more communication systems because I'm remote. Is it that way around? Or not necessarily?
Not necessarily. And what you said, you would think would be very, very appropriate. But what ends up happening is that in these locations, they often say that, oh, we are doing a minimally invasive procedure.
That's what I was just going to say.
Right?
Just a whiff of gas.
It's going to just be a MAC. Just a sedation will be sufficient for the patient. But what you don't realize is that, these patients who are coming to these locations aren't necessarily surgical candidates because they're so sick.
They're too sick.
They're
actually,
right.
put to sleep.
They're too sick to have surgery. That's where they're coming in for these minimally invasive procedures, and you can just do a MAC. But often in these locations, these patients are very sick. The ergonomics of the location may not be very good. If you are in cath lab, it's very dark. You can't see what's going on with the patient. The patient's head may be very far away from you because they're obstructed by the X-ray machine. So it can be very difficult to provide safe care in these locations.
Yeah. Is there any kind of technology or anything that you guys are embracing to kind of help in this? I know capnography and some of these other things, adding that in has been relatively new in some of these areas.
Yeah, capnography definitely is important. Obviously, all the standard monitors. Obviously, you have to have the same kind of monitoring standards in these locations as in other locations. But sometimes because the procedures, I will acknowledge the procedures are short sometimes. And in these 6 patients, you may not necessarily want to do a lot of invasive monitoring. So sometimes non-invasive modalities that can measure cardiac output and things like that can also be very, very helpful in these locations, especially for those sick patients.
And in the drug world, I'm guessing we're about due for some new alternatives. We've had certain drugs, we should be careful what we name, that have been around for quite a long time. They're wonderful fast on, fast off drugs. But they were associated in the operating room with quite a lot of hemodynamic instability, quite a lot of drops in blood pressure. Now, some of the other drugs that are very stable had very long hangovers.
That's true. Yeah.
Are there any new kids on the block?
Not so much that I've heard. I think what is new is using the old drugs that we have in new combinations.
Great.
So new, lower infusions of adding on 2 different types of infusions together have been pretty useful in keeping patients safe in these locations.
What kind of training do you foresee in the future of specifically Nora for anesthesia providers? Because, there is a nuance. I remember when I first started doing, we first started doing endoscopies, and I was like, oh, wow. Okay, well, this is different. And, there was definitely a finesse to it. Like, do you see even a whole nother training type of pathway for this?
I don't necessarily see another training pathway, but definitely a greater focus in residency education. Yeah. So a few years ago, the Graduate Medical Education Council required that residents have a non-operating room anesthesia rotation. And that is defined institution to institution. I think there is definitely an opportunity to standardize what is learned in those locations, and also to integrate simulation and team training into those rotations as well. That would be pretty helpful.
Yeah,
it's kind of more rational to do your Nora rotation than it is to do your cardiac or a pediatric, because you're much, much more likely.
Very true.
We want to do it all in training.
Right.
But actually, if you had to knock one out and knock one in, the rational way around would be to knock the Nora in.
Yeah. You're not going to be expected to take care of a patient with an aortic dissection, after graduating from residency, but you will, for a patient who's coming to the cath lab for a STEMI or something like that. Right?
Yeah, absolutely.
Can I make a tiny Knight's move for a second? Because we've been having a lot of conversations recently about ambulatory surgery centers, which when I know what they are, and I visited them, but if you see pictures of them, they look like operating rooms, but they sound as though they're in potentially remote locations that are operating rooms.
Yeah.
Is this a sort of middle ground for the challenges that you're talking about, or is it's operating room, don't worry about it?
I would say yes, because, ambulatory surgery centers don't necessarily have all the resources that a hospital has, right? If something happens in an ambulatory surgery center, they have to call 911 to get their patient to a hospital. So I would say just because it's an operating room doesn't mean it still has like all the resources that a hospital operating room would have.
So all the same principles: educate, communicate, get the right equipment, the right people, personnel, etc.
Yeah.
Great.
Sure.
Really important. Well, Emily, it was great talking to you about Nora. And this is, again, I think we need to have more conversation about it. You were talking about the residencies. Like, it's people want the really cool, great cases, and as an educator, you're kind of like, well, I hate to send them and spend all their time doing, IR or MRIs or things like that. But I think Monty made a really fair point.
You need to get good at it.
You do.
For
You
sure.
absolutely need to, because your first day, you could potentially be.
Oh, yeah, for sure.
In that side. Well, Emily, tell us just a little bit. I know that you're very involved in social media and, kind of socializing medicine. Tell us just a little bit more about that.
Well, I primarily got involved in social media for professional reasons. Really want to engage more with the educational aspects of anesthesia, and also got really involved with the Anesthesia Patient Safety Foundation at that time. Originally, I was asked by someone with the APSF to run their social media ambassador program. So was charged with basically recruiting people who are prominent on social media, having them, focus, or having them retweet and repost about things related to patient safety. So primarily got involved that way, and then realized the power of social media, that it had the ability to make virtual connections, to create virtual mentor-mentee relationships that have really expanded beyond that into real relationships. So it's a really powerful tool, I think, for professional development.
Yeah, absolutely. What about like clinical practice? How do you think it's affecting clinical practice? Because I know with just, you think about like Facebook and everybody has their opinions about it. Good conversations. I mean, we try and do a little bit of myself, but like, where do you really see that?
Yeah, I definitely think it has the power to transform clinical practice, because I think there is that adage out there that it takes 17 years for research to be translated to the bedside, right? There was a study a few years back comparing radial approach to femoral approach for STEMI interventions. And basically demonstrating that radial approach was better because there were less vascular complications. And the American College of Cardiologists and their social media team kind of put that research out there. They created a whole new brand new hashtag called Radial First, spread that all around, and they were able to basically convert their entire cardiology community to choosing the radial artery first for vascular intervention. That only took a couple of years. It did not take 17 years. Wow. So yeah, it really has the power to transform clinical practice.
Yeah, that's super cool. Well, again, thank you for taking the time during the meeting. I know you're super busy. I see you kind of running around everywhere, but we really do appreciate it. I think, the things that you're sharing are all things that we can go home and kind of take with us and figure out how we do it.
Congratulations for the program to you and all your colleagues.
Oh, no, thank you so much. Thank you for the opportunity.
Well, thank you for listening to TopMedTalk. You can always find us on your favorite social media platform. So hopefully, Emily, whenever you see this come up, you can retweet this.
Yes,
too.
I will.
Repost. We're on Twitter, LinkedIn, Facebook. You can also find all of our content from the previous SCA meetings and everywhere we've ever been, actually, right, Monty? On TopMedTalk.com. So check us out there. Thanks so much for listening and have a great day.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.